Nicole Karlsson is here with us from the Division of Public Health Services to talk about occupational health and COVID-19 and health equity. And Nicole, we welcome you, and the floor is yours.
Thank you. I am going to attempt to successfully share my screen after all of this time of using Zoom. So you see my full PowerPoint here.
We do.
Great. Okay. Well, I really appreciate the opportunity to present and talk about occupational health today. My name is Nicole Karlsson. My background is in occupational epidemiology, and I currently work for the New Hampshire Environmental Public Health Tracking Program here at DPHS. And my slides sometimes work. So I'm going to be talking about occupational health and COVID-19 equity today. It became evident very early on, and everyone recognized that healthcare workers were going to be at risk from COVID-19. But not long after that, it became evident that a whole lot of other jobs were also at risk, even though they were less studied and less talked about. All the way from processing plants, manufacturing, construction, wholesale, retail, postal work. When you look at these jobs, they're the kind of essential jobs that have been talked about so much, but they were sites of outbreaks. And not just outbreaks, but they were sites of excess death. A study of death certificates in California found that occupations with the highest excess deaths during the pandemic time were things like cooks, warehouse workers, agricultural workers, bakers, and construction. And those jobs had elevated mortality rates above healthcare workers. Also within certain plants, certain groups were highly vulnerable. One Wisconsin food plant, green bean plant, where 1 in 14 of their migrant workers died in one site. So how does work relate to health equity? Well, occupation and a lot of these other factors are really deeply intertwined and really challenging to pull apart, but really important to think about as a unit. Issues of race, ethnicity, gender, immigrant status, language, and the structural factors that determine health. I'm going to give just a few examples here because I could go on all day. But we know that jobs, they're sorting for structural reasons into various occupations and industries. And so who is doing these high-risk essential jobs is not evenly distributed across all demographics in our society. And the same can be said for who has the ability to work from home. I saw one study that found that Hispanic workers, only 15% had the ability to work from home, increasing numbers, Black, white, and Asian Americans. And there was a strong gradient also by education level, where people with a high school education level or less had less than 10% ability to work from home, whereas people with an advanced degree had over 50% of them were able to work from home. So when they say we're all in this together, it can be very, very different. Different jobs and have differing access to paid sick leave and health insurance, which we know are really important. And then low wage workers tend to have a lot of these factors that we know are higher risks for COVID, and they all kind of combine in these ways that, again, as I said, are hard to pull apart. But for example, you're a low wage worker, you go to work in one restaurant, that restaurant doesn't give you enough hours, you go to work in a different restaurant, you've got 2 different exposure bubbles. You go home, you live with a brother who worked in a manufacturing plant and has a 3rd exposure bubble. You live with a parent, you live in a multi-generational household with a grandparent who is a much higher risk for COVID. And that person, even though they're not working, now has all of this elevated risk. Even things that we don't usually think of work, but structural factors like commuting alternatives. You don't have a reliable vehicle. You probably are going to your shift carpooling with a bunch of other coworkers. So if your workplace, even if your workplace puts in things like 6-foot distance, really good ventilation barriers, then you get in the car and you drive New Hampshire distances with your windows rolled up in the winter. That really should be considered a factor too. And one thing that I always talk about is I hate the expression working age. Over the past decade, we have seen increasing numbers of older workers being part of our workforce. The numbers that we have for New Hampshire, most recent numbers we have in 2018 is that 8% of the New Hampshire working population was above 65. So we need to stop thinking of the working age of 18 to 64 being who we're thinking about and who we're planning for. Work also has an impact on vaccine equity questions. One survey found that among unvaccinated adults, nearly 50% were concerned about missing work because of side effects, whether they don't have paid sick leave or whether they're just going to lose their job if they don't show up because they're too sick to work. And we know that who has access to paid sick leave is not evenly distributed as well, with Hispanic workers being least likely to have access to paid sick leave. And if you look at this chart on the left, you can see that the fear of missing work due to side effects of the vaccine, 64% of unvaccinated Hispanic adults reported that, 55% of Black working adults, and 41% of white adults reported this as a concern. So I'm going to go here and talk a little bit, transition into some information on what I've been working on. I am a project lead for New Hampshire for the COVID Worker Callback Survey Project. And it is in collaboration with the Bureau of Infectious Disease Control at DPHS and the UNH Occupational Health Surveillance Program. And we are one state among 6 states that are collaborating with the National Institute for Occupational Safety and Health, NIOSH. And the goal of this is to understand the work experience of non-healthcare workers who've been understudied, both in New Hampshire and nationally. And we talk to people who worked outside the home and ask them questions about the kind of precautions and kind of exposure risks that are happening to them. So whether they were infected at work or not, we want to know what their work was like. So it was important that this, knowing what we know about work, that this survey try to have reach health equity goals. So NIOSH itself produced an official Spanish language translation. We had somebody on staff at DPHS who was a native Spanish speaker and tested with the fluency and competency testing, who conducted all of our Spanish language surveys. We were able to use over-the-phone interpretation for other languages that we did not have our own speakers of. And when we did, it's really hard to know what the demographics of the working population during COVID are, because as you know, COVID completely shook up everything we knew about work. In a lot of ways. So, but we did find that comparing to what we knew about the New Hampshire working population before COVID, we did have overrepresentation in our survey among Hispanic Latino, Black African American workers, surveys that were conducted in languages other than English. We had overrepresentation in people who did not have health insurance. And we also, when we looked on the county level, which is where we recorded who was contacted, our calls were geographically representative of the case concentration at this level. So I'm not, this is just a really quick presentation and I'm not going to talk a lot about that, but I do want to give you an example and touch on one thing from our preliminary findings, which is about the kind of interventions that workplaces were taking. So in occupational health, we talk about a hierarchy of controls, which means that interventions that are done on the individual level, like PPE, tend to be the least effective, and more structural changes like engineering controls at a facility, such as ventilation, and workplace practice changes, those tend to be more and more effective. And I know you all have this public health perspective, it's probably very similar that we talk about interventions that target structural or bigger picture change rather than focusing on individuals as for effectiveness. And it's very similar concept in occupational health. So what did we find in our survey? we found that the most frequent interventions were really these individual style interventions. Like 95% of the people said their employer provided them hand sanitizer or requiring them to wear masks. But our least frequent interventions were things like improving ventilation or reassigning the most vulnerable workers to be protected from COVID by working from home or other options like that. So I think that's important to think about as we continue to live with COVID, and that as we think about other infectious diseases in the workplace. So just as I wrap up, I thought, what 3 messages would I love you to take away from this presentation? When you're out in your job, when you're doing what you do, talk to people about their work. Just make it a topic of your conversation. But please keep the understanding that for a lot of people, it can be very hard to overcome fear about talking about work. People do not want to lose their job. People are afraid things are going to get back to workers. So understand what you're doing with this conversation and be comfortable talking about it. If you collect data or if you have partners that collect data, let them know that occupation and industry are important variables or pieces of data to collect for health equity. If we want to understand what's happening in workplaces and we want to understand and act and intervene. And finally, if you have the opportunity, think about the hierarchy of controls when it comes to interventions and look for interventions that are higher up and more protective for workers. Thank you. And I'm happy to answer any questions.
Thank you so much, Nicole. Does anybody have any questions for Nicole about the presentation? You can either put them in the chat or just come off mute and ask if you've got something. While we're waiting, I've got a question.
Okay.
Oh, sorry. No, I'm going to save my question because Heather's got a question in the chat. So let me read that. Is there a tool set you would recommend to collect the occupational data?
Okay. So we actually, something that we have implemented ourselves, there are some very simple training videos, and there's actually a training little video that comes either that's produced by NIOSH that is available on YouTube, or that is produced, we have one that's specifically by the New Hampshire UNH Occupational Health Surveillance Program that has a little quiz afterwards that gives you a little certificate saying that you took it. And what it really does is help you think about industry and occupation. And so it's not a way of recording it, but it helps you think about what is industry and what is occupation and how do I ask the questions to get good answers for these. And I always encourage, they're 10 minutes long, each of them. They're very similar, so you can choose one, whichever one works better for you. And I can put the links to both of them in the chat after this, because we have asked everyone, every time I have a talk about this, I ask internally at DPHS, I ask people to take these and spend 10 minutes of your time doing this and learning about the concept. So thank you for giving me the perfect question that I would love to answer.
Is there if there's a link to that, Nicole, would you be able to put it in the chat, or we can
absolutely
send it around after if that's easier?
Yeah, I'll put it in the chat, but I'll also I will also make sure that you have it written as well.
Great. There are a few more comments. If you don't mind, I'll just read them out loud for everyone. So Heather is saying that would be helpful for the toolkit. And trying to put it on an intake sheet is what she is trying to establish. So I don't know if you have any thoughts about that, if that will work. And then Tiffany has asked a question. As public health practitioners, it seems really important to help dispel misinformation about workers. What do you say to people that say people don't want to work?
Oh my goodness. That is a complicated question. I mean, the short answer is that there are many structural factors that can make it hard for various people to work depending for various reasons, be it pay, be it flexibility, be it access to work, benefits. That's a fabulous question that I haven't put in a easy way before to respond to.
Thank you. Oh, lots of comments. Matthew is asking, when you design your study, how do you determine if the COVID exposure occurred in the workplace versus the home or other locations?
So the survey that we gave was a very structured survey that was designed collaboratively with all 6 states. So if I were designing it, I might design it a little bit differently, but as a collaboration, what we came up with was we asked people if they knew they were exposed at work or they suspected that they were exposed at work. And we also asked people if they knew they were exposed outside of work, and then we asked some kind of risk questions that might indicate higher risk for types of exposure. And we also recorded if we got the calls based on, we pulled them from people who had been interviewed in the previous week because we didn't have to have too much recall. So we also have records of whether they were part of a known outbreak. So even if they didn't know that they were exposed at work, if we recognized that their workplace had had an outbreak, we were able to factor that in as well. It's really hard to know. And this is part of what the problem has been early on, is like, how does workers' compensation going to deal with this? And a lot of workplaces have fought back. Well, you can't prove that this person caught it at my work. They were going out to a restaurant. They were doing that. And that has been a huge, huge issue for occupational health throughout COVID.
And then,
can I ask a question?
Yeah, go ahead. I just was going to share the comment in the chat, but go ahead, Trini.
Oh, yeah. Well, just a follow up to the original question, which you shared, there's some trainings. Are there like standards or codes for industry and occupation, or like a source that we should look at for, for knowing how to, I mean, I understand you have the training, but is there also guidance or set ways that jobs are defined?
Sure. So there's different ways to describe define industry and occupation, but what I tend to use is the NIOSH, the National Institute for Occupational Safety and Health, has an auto-coding engine that if you answer the questions well about industry and occupation, it will process your words and give you back various coding devices. There's industry and occupation codes. Either there's census defined codes and there's also ones called NAICS codes and SOC codes. The standard occupation codes is the SOC codes, and NAICS, I think, is North American Industry Classification System. And those have a very defined structure, and it really, we're dealing with large population data sets that we want to define in a certain way. It's really great to have this resource through NIOSH that will process them, or you can look up individually to sort them. But that said, they're not always perfect for all conditions. A lot of states have, for example, decided to use different classification systems for COVID because these don't well classify, for example, if you are in certain specific industries or customer facing, for example.
Thank you.
And then Nicole, I just want to share for everybody in the chat. Beth has also shared that access to childcare that people trust can also make it hard for families with young children to engage in employment, especially for families with children with multiple disabilities, nonverbal or wheelchair bound, and or children who are with immunosuppressive problems.
Absolutely. Yeah, this is part of, I think of I didn't expand on this too much, but childcare is definitely one of the structural factors that makes it harder for certain people to be working, particularly during COVID. And it's particularly when we talk about the impacts that these outbreaks have had in different workforces, your childcare provider is sick or has to quarantine or things like this. But yes, or you can't have your child with health concerns in some of these settings that you would have had them in before. So absolutely, all of these factors. It's not just about wanting, it's never about they don't want to work. That's never the thing.
And then maybe we can close it out with Allie's question in the chat, which is, you presented some preliminary findings. Are these available to the public? And do you have a sense of when the results will be published?
So we have not put together preliminary findings that are available to the public yet. We've done we did like one presentation midway through our survey just with some preliminary findings to the Governor's Economic Reopening Task Force. But the findings are not available to the public yet for the state of New Hampshire. And these are just for the state of New Hampshire, to be clear. We are nationally, July 15th, is a deadline that we are all states combining our data, and the analysis is going to begin nationally and will be done over the summer. But the state of New Hampshire, for our specific data, intends to have some fact sheets to be available hopefully by the end of the summer. And I'm kind of new to the state of New Hampshire, so I apologize that I don't know where these are most likely to be publicized. But if anyone's interested in being kept up to date on this, I am I'd be thrilled to take an email address for you and keep you updated when we do share some of this.
And Nicole, I'll go ahead and speak on behalf of the group. Hope they don't mind, by saying I think we'd be really interested to have you back when those are available as well, maybe to share them with this group, if you'd be interested in doing that as well.
Great, I would love to. When we ask people a lot to, they come home from work, they're doing all this, and we say, take 20 minutes of your time or more and answer these nosy questions about yourself. So the more we can get the word out there, the more we can use that data and not just have it sit and be missed, the happier we are, the better we're serving the public. So I would love to.
Great. Well, also on behalf of the team, of the group here, I'd like to thank you so much for sharing your time with us today. And I think this was really fascinating and a sort of a missing link, a missing piece of the conversation that we've been having. So really appreciate it. And we welcome you to come back and stay with us if you've got time every other Friday morning. We're always here and happy to have you with us, providing your perspective. And with that, I think we will go ahead and shut down the recording. So we will stop that. So we will no longer be recording, and